let's go through the shoulder exam, docs. There's no joint that gives doctors more fear and trepidation than the shoulder joint, because it is a complex joint, and there's so many different movements, so many different things that can go wrong. So I'm going to try to break it down for you into the main 2 or 3 tests for each area that can go wrong. And if you get this exam down, you're going to be a master at examining the shoulder and being able to diagnose what the pain generator is. With all my exams with extremities, I always start with range of motion, same with the spine mostly. So the motions that I screen through, I'll go through those. So Noah, I'm going to have you mimic me, so I'm going to stand, but we'll do that arm there. The first one I want you to do is just to raise it straight forward, high as you can, and then straight back. So flexion, extension, then bring your arm out, thumb up, and then raise your arm high as you can, okay? And then we're going to go straight out, then we're going to go across body. So we've done flexion, extension, abduction, now horizontal adduction. Now straight out, bend your elbow halfway, and then do this movement, and then do this movement. So internal, external rotation. Of course, any movement that is restricted or that you need more testing on, you can do all of these passive. So flexion, extension, abduction, horizontal adduction, bend your elbow now, internal rotation, external rotation, okay? Then, usually what I do with shoulders is I start to screen the rotator cuff. If I got any indication that there's rotator cuff involvement, I look at that right away. So in a situation like that, Noah, keep your elbow right to your side. Push out right here. So there's infraspinatus, teres minor, resisted external rotation. Pull in right here, Noah, subscap, and right here. Hold up, don't let me push down. Boom. Supraspinatus, let it down. If you see weakness in those, or it gives, or there's pain, you know there's something going on with the rotator cuff. So active, passive, resisted motions are important. The other thing that's sometimes helpful when you're watching some of these motions, I usually watch from the front, but it's also not a bad idea to look at them from face this way now, especially abduction. And you can do these bilateral at the same time, all these motions I just showed, okay? But it's important, bring your arms out, thumbs up, and raise them up high as you can. It is important to look to see what their scapula does when they do abduction, okay? And all the way down, okay? To see if there's winging of one of those or if one elevates more than the other. Okay, let's do some more rotator cuff tests. So we've tested range of motion, active, passive, resisted. We showed you the 3 resisted ones you want to do for rotator cuff integrity. Another test of rotator cuff is called, this will be our first orthopedic test, empty can test. So we bring the arm about 40, so 90, 0, about 45 degrees, thumb down, Noah. Don't let me push your arm down, resist. That is a great test for testing the supraspinatus. If you've already ruled out there's likely no tear because it's not given away, the other condition that can cause pain there would be supraspinatus tendinitis or tendinosis. Empty can test is your best test for that particular thing. If you do a rotator cuff test and say you're at this one and that arm kind of gives away and you're suspecting a rotator cuff tear pathology, the next ortho test I would do is Codman's test or sign. In this, you passively bring the arm all the way up into abduction, and then you say, Noah, I'm going to let go now, and I want you to slowly lower your arm all the way down to your side. Okay, lower it down, nice and easy. And he, of course, has no trouble, but the person who has trouble, you'll raise that arm up, and they'll lower it, and then it'll drop. That is a classic sign of a rotator cuff, either partial or more commonly a complete tear. It's called a positive Codman's sign. A couple other things. There's a test called the belly press test. So now I want your hand on your belly, your elbow forward like this, and I want you to hold your hand on your belly. Don't let me pull off. And this That is a great test for subscapularis. And if they can't hold their hand to their belly, it pulls off. That's a sign of subscapularis weakness. Turn this way, Noah. Put your hand behind you. Keep it there. Then there's another test called the lift-off test. Noah, you're going to keep that elbow bent. I just want you to lift your arm or your hand right off your back. Yeah, that's the lift-off test. They should be able to do that. Somebody with a rotator cuff problem, they can't do it, and that's a sign that the infraspinatus is really having trouble. Okay? All right, Noah. So come back this way. So those are some of the tests that I would do for rotator cuff. Empty can, Codman's, the belly press test, the lift-off test. Very good test for rotator cuff along with those resisted motions that we taught. Okay, a lot of trouble. People have trouble with anterior shoulder pain. It's important to test the biceps tendon for biceps tendinosis. So Speed's test is a good one. That we just keep the elbow extended, the arm straight in front. And Noah, don't let me push your arm down. Resist me. And if that causes pain in the front of the shoulder, it's a pretty good test for biceps tendinosis. The other one I use is something called Jurgensen's test. And this one, their elbow is partly bent, their wrist is pronated, and then what they do is he's going to bend his elbow, let your elbow bend up, and rotate your wrist at the same time. So this is the movement, Noah, like that. And what I'm going to do is I'm going to resist that. So I'm going to make it hard for him to supinate and to flex. So there's your start point. Do those movements, Noah. That really puts a lot of torque right on the biceps tendon right there. And so Speed's test and Jurgensen's test are the two you want to do if you suspect biceps tendinitis or tendinosis. Of course, you'll get these patients then that have what we call impingement syndrome, where let's check your range of motion, raise your arm up to your side, and think, I can only get it to here. Then it starts to hurt. But if they do forward flexion, they're fine. So abduction impingement syndrome is very common in the shoulder. So a couple tests you'd want to do. The best one is called Hawkins-Kennedy test. And that test, their arm is brought forward, their elbow is bent like this to 90. You stabilize the shoulder, you bring the arm right up to your chest, and then what you do is you're going to rotate that arm like this. Just let me move it, Noah. This. If they have impingement syndrome, they're going to flinch, and then you're probably only going to maybe get it to here, unlike way down here with what Noah can do. So the Hawkins-Kennedy test is a very good test for impingement syndrome. And then we would do Neer's test. Neer's test, you grasp the shoulder, you grasp the elbow, and you apply a little pressure down, and then you raise the arm up. If they have impingement syndrome, usually you get to there, and then it starts to hurt, okay? Or they can't bring it up that far, but you're doing all the work. But so Hawkins-Kennedy and Neer's test are your big two for impingement syndrome. A lot of people also have bursitis. They get subacromial or subdeltoid or subcoracoid bursitis. The most common is subacromial bursitis, where they'll just have pain right here. A good screening test for that is called Dauburn's sign. And you will palpate the area and be like, find an area that's, it's tender right over that subacromial bursa. And then what we do is we passively abduct the arm, and if that point of pain moves medial or your finger is no longer over it, in other words, it was really tender for them when I pushed here, but when I bring it up here, I can't find that area of tenderness anymore. That's a positive Dauburn's sign, and it's significant for subacromial bursitis. Okay? Athletes, a lot of times, they get recurrent dislocations and problems. When I was in high school, I dislocated this shoulder 7 times in this bunch. I had instability in my shoulder. And so there's a few tests you'd want to know about, to learn to diagnose instability. One is called apprehension test, and this one, we bring the arm up, we bend the elbow, we put a little pressure behind the shoulder, and we bring the arm into this. Somebody that's prone to dislocation, they're literally going to be, you can almost tell like, oh, I don't like that position. They're apprehensive about it because most commonly that humeral head dislocates anteriorly. So putting that, if that is like, that hurts or it makes them feel pretty apprehensive, like they're vulnerable, that's a positive test. And then what you can do is called the relocation test after that, where you put anterior pressure and then do it. And if you put anterior pressure here and then they don't feel apprehensive or any pain, that is a positive indicator of instability. A couple other things, Noah, turn this way. Sometimes you want to do what's called a sulcus sign. This is a simple test to look for instability. You grasp right above the joint, you grasp right below the joint, and what you do is you pull down. And with the instability, you'll just see like this little indentation where the skin kind of buckles in, and you can see that humeral head slide down. And with him, we don't see it, but some of his instability, you'll see that slide down, you'll see it's called sulcus sign. All right? The other one I'll do is called load and shift test, where we'll pull down, hold here, pull down, and then we will shift the humeral head forward and backwards. Somebody that has instability, it'll just clunk, 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 clunk. It'll just go back and forth. There's excessive motion there. It's called load and shift test. And then finally, people, a lot of times the hardest condition to diagnose with the shoulder is a labral tear. Now I want you to bring your hand on your waist. So bring your hand out like this and put it right on your waist, okay? And then what I'm going to do is I'm going to push your arm this forward. You're going to kind of push back against me. This is called anterior slide test. So I'm going to push in. And they resist when you do that. If that creates pain deep in the joint, that is a very strong indicator they have a labral tear. Right? The other one that I love to do, and I think is the best test for labrum, is called O'Brien's test. Face towards this way to get on. O'Brien's test, you bring the arm straight forward, you turn the wrist down, you bring it about 10 to 15 degrees into horizontal adduction. Keep the elbow straight, and then don't keep that down. Don't let me push your arm down. That. What will happen with that is they will get deep pain right in the joint there. And that's testing the bicep attachment into the labrum in there, and they'll get pain. So anterior slide test, O'Brien's test are really good ones. The other one that I do, and I'm going to have you lay on your back here, Noah, and right up there. The final one that you want to do for labrum is called the Clunk Test. And this one, and this is about the only test I do from a supine position. So most of your shoulder tests you can do either seated or standing. I had them do standing. You could do probably most of those tests seated as well, okay? But either way works pretty well. Clunk test, we bring the arm into this abducted, externally rotated position. We hold it, we get on the elbow, and then what we do is we push medially inward, and then we rotate the arm into internal and external rotation. So it's like we're driving the head into the socket, and then we're internally and externally rotating. And if they get clunk, clunk, clunk in there or pain, that is a pretty strong indicator of a labral tear. Okay? Noah, sit and face this way, please. And then finally, with shoulder, obviously palpate relevant anatomy. So, you know, common conditions will be bursitis, so subacromial, subacromial, subdeltoid bursitis, biceps tendon, supraspinatus tendon. Then I always palpate the belly of the rotator cuff muscle. So supraspinatus, teres minor, infraspinatus, subscap in the armpit are very relevant things. Biceps tendon and the upper part of the biceps muscle. And then sometimes it's important to palpate the medial shoulder blade, the levator, the rhomboid major, rhomboid minor. If you got impingement syndrome in the shoulder, take a set of x-rays because you're looking to see what the acromion is doing. If they got a type 1 acromion, it's normal, but if it's a 2 or there's a little slope to it, that makes them more vulnerable, or a 3 where it's more beaked like that, it'll increase their odds of having subacromial impingement syndrome. If they have a lot of crepitus in the shoulder, there are some cases where they get osteoarthritis, of course trauma. Those are all important things. Finally, I forgot to do one test, a lot of orthopedic tests for the shoulder. We get a lot of athletes that come in with injury to the AC joint, sprain strains of that, partial dislocations, and the AC joint can also get arthritis in. So one of the tests that's very useful is called cross arm adduction. When we bring the arm across, horizontal adduction, and then you pressure it. If they got something going on in their AC joint, that test will usually bring it up. And finally, do an upper extremity index. You get that test though, Master Docs, the motion, the resisted things, those orthopedic tests, you will have a world-class shoulder exam. That exam I just showed you is better than any medical orthopedist notes I've ever seen on a shoulder, and that's a high-end exam. Master it and you'll be amazed at what you can do with shoulders.